welcome everybody to the 14th UCD COVID seminar series. Delighted to see you all back with us today. And we're very excited about our speaker, whom I'll introduce in just one moment. Most of you are familiar with the format, a talk by our guest speaker, and then about 10 minutes or so at the end for question and answers. And looking forward to that very much. Without further ado, I might introduce our speaker. The webinar is co-hosted by myself, Fiona McNicholas, my colleague Blonit Gavin and Paul Harkin from UCD, and also the College of Psychiatry of Ireland. So we're really very honoured to have Professor Argyris Stringaris presenting today. He's a child psychiatrist trained in the UK from King's College and worked in the Institute of Psychiatry, done clinical and research there, and is now working in the United States and is a lead in NIMH. And really, Argyris, your area of expertise is very much on youth depression. It's an award-winning area, and we're absolutely delighted to have you talk to us today. I guess as we're going into a further phase in Ireland where there's real concern about increases and where restrictions had to be reimposed a little bit, the ability of young people to continue to remain resilient and not have, you know, depressive episodes that may become much more pathological, I think is a cause for concern. So if I can hand over to you and look forward to the talk. Thank you very much.
Thank you very much. I have to say that I'm deeply honoured by the invitation. I want to thank the organisers very much for the opportunity to talk to people in Dublin. Whilst I had lots of close friends and colleagues of the Maudsley who were Irish, from very fond memories, I've never had the opportunity to present in Dublin. So this is wonderful. So the title of my talk is COVID and Adolescent Depression. And I'm funded only by the National Institute of Mental Health, so I have nothing else to disclose. And let me just give you a brief overview of my talk. So first I'll talk a little bit about depression. This is stuff that many of you will probably know. I'll talk about COVID and the pandemic effects and just try to give a bit of an overview of it. And then about its effects on healthy and depressed adolescents so far. And I will be presenting some of our own data about this. And I'll end with some conclusions and discussions and before we open up for general discussion. So depression, as you know, is a potentially lethal condition. Adolescents with major depression are up to 30 times more likely to die of suicide. This is very important to remember. It has its origins in early life. It has a cumulative prevalence of about 10% by the age of 16. And it's a global problem. It's not just a problem that we encounter in developed countries, but also in developing countries and around the world. And it's the leading cause of years lived in disability. This is an idealized approximation of the relationship between the cumulative incidence, so the accumulating cases, and new cases of depression and age. And what you can see here is that there is a steep rise in the new cases between the age of 15 and about 25, right? So this is a critical time when new cases come online, when people kind of fall in, essentially. So it is the time when youth, mental health workers, child and adolescent psychiatrists have to kind of intervene, or at least be aware of the increase of the incidence of depression. And it becomes very relevant when we think about the pandemic later on. These are top 10 reasons for disability, years lived in disability, according to the World Health Organization. The coding here is blue for males and red for females. And what you can see is that unipolar depressive disorders are right at the top. They cause more disability-adjusted life years lost than road injury, iron deficiency, anemia, pretty much everything else. So they come out top for adolescents, and you can see that more so for females and males, but still quite substantial. So it's a global problem, as we've said, and potentially lethal. And In terms of its lethality, just to remind people that, for example, in the United States, rates of suicide overall have been going up, both in males and in females, over the last 10 to 15 years. So this is deaths per 100,000, and this is years, and these are data from the NCHS. So quite worrying increases in suicide. So we know that depression is also a condition that is not very easy to treat necessarily. So people will remember that we have a great proportion of non-responders, depending on when exactly and how exactly one defines a response and remission. It could be up to 60% who respond and the rest do not respond. And of those who do not respond, some respond to the second wave of treatment, but not all. And some of those people who respond or remit will experience a relapse even within a year after successful treatment. So there are several challenges with depression that are kind of important to take into account. And a lot of our research, the research I'm leading at the NIMH, is about understanding the mechanisms of depression and trying to devise new treatments. So that's a little bit of background about depression and its prevalence, its epidemiology and treatment. I want to talk briefly about its etiology. Now, a proportion of the why one might get, the explanation of why one might get depression are, of course, shared genes that increase the reasons for someone to become depressed. There are also clear environmental effects, what we used to call life events, and random life events, something awful happening, a disaster of some sort, or life events that are somehow in the relationship between the person themselves, the characteristics of the person, and their environment. So imagine a child who has certain characteristics, say is overactive or something like that, and can incite reactions in their environment that could be depressogenic, could lead to that child being depressed. And there's so-called passive gene-environment correlations. It's another route to mental illness, which is, imagine having a mother or a father who is depressed. What happens is there's both probability, high probability of passing on genes that are associated with depression, but also passing on an environment, creating an environment for the child that is depressogenic. So, for example, imagine a young child whose mother is depressed and is very under-responsive, or a father is depressed and behaves in ways that could be depressogenic themselves. So all this, and there's gene-environment interactions, the fact that certain people, by virtue of the genetic makeup, are more or less vulnerable to the environment. I'm putting this up here because it shows that the causal pathways to depression are complex and not entirely well understood. So I'll be coming back to this towards the end of my talk. Where would you think that the effect of a pandemic would be here? I mean, they're clearly not a purely genetic effect, in the sense that they don't operate directly on our genome, or at least not on the genetic propensity for psychiatric illness. But they are an environment, clearly. But remember that it's not just a pure environment that may affect everyone in the same way. There are other things that play an important role, be they familial, societal, and pre-existing conditions. So we'll come back to that. So what is COVID-19? COVID-19 is a coronavirus disease, one of the coronaviruses. It's not the 19th one, it's just the 2019 coronavirus. There's been confusion about that. This is the actual designation of it. It's a SARS coronavirus, and we've had those before, as I'll be saying in a minute. Transmission is thought to be person to person by respiratory droplets and like. I think when I last looked, there had been about 780,000, close to 780,000 deaths since the beginning of the pandemic globally, and you can see the distribution of deaths here by geographic region. So quite a substantial number of people have died, unfortunately, because of this coronavirus. And there are countries with higher and countries with lower case fatality ratio. This is can also be skewed by the number of tests done and all that, but it gives you an indication that about differences, geographic distribution differences of problems. Just to remind you, the earliest report of symptoms was probably around December 2020. By the 30th of January, there was a public health emergency of international concern report by the WHO, and on the 11th of March, we had the declaration of it being a pandemic. I don't know, people may now remember this as a different era when this happened. It seems to me like a vague old memory now. Just some of the effects of the pandemic. This is the unemployment rate in the United States, and you can see this is the Great Depression, right? These are the effects of the Great Depression. Yeah, I hope you can see my cursor. Here is the situation in April 2020. So you can see that never after the Great Depression have we had such high rates of unemployment in the United States, which is quite, tells you quite a lot, and it may be increasing further. Other interesting phenomena, some of which may not be that bad, just to give you an indication, is this is an interesting snippet from the Financial Times about roads emptying across the world. Let's just take the example of Rome, which I think is quite striking. This is the historical average, what the Italians, how much they would drive on their roads during a week, any day of the week. And this is how much is happening during the pandemic. So you see a vast decrease. I tried to find one for Dublin, but I couldn't find one, unfortunately. I don't know whether that reflects your experience as well. Certainly, pictures like this of an empty Times Square in New York on a regular evening, this is March 2020, are quite unusual. So it's quite a striking thing, this pandemic. It is really a pandemic. It got around the world. It is now affecting people around the world. It's everywhere. It's everywhere, even if we don't encounter the virus as such or its effects. We hear about it in the news all the time. It is a very unusual situation. So what should we expect of COVID in terms of mental health consequences? Well, we have some prior knowledge from disaster research. So, for example, this is what happened after 9/11. The World Trade Center attacks. It was a big deal at the time, and some had a sense of gloom. It was different, of course, because it was a very localized event, but still, it was obviously all over the news, and it affected a lot of people, particularly people locally, as I'll show. There are other things like the big some of the big oil spills. So they can have huge consequences, such events for mental health of people. So this is a study, for example, that shows some of these effects 6 years later after the event. There's previous SARS pandemics, as people would recall, the 2003 SARS pandemic. You can see here young ballet dancers with masks on, and a global concern. Newsweek was saying the new age of epidemics. That was back in 2003. Overall, what we find is that there's an increase in disorders, particularly emotional ones, in the context of such disasters. Major depressive disorder is one of the most prevalent post-disaster mental health problems, and MDD is the second most commonly observed psychiatric problem after PTSD and post-traumatic stress disorder in such situations. So, and you can see that the estimated prevalence of say PTSD after such disasters is quite high. It's quite high in direct victims. So the closer you are, the higher the chance that you will get PTSD. It's quite high in the rescue workers, and this is important to remember also in terms of medical personnel, people who work on ICUs or in hospitals in general at the moment. And there's an effect on the general population. So we have a bit of an idea of what to expect, and I think the general idea is, gosh, we should expect an increase in mental health problems. So indeed, there's some data that I've tried to put together with the help of my colleagues from the Household Pulse Survey that is conducted annually over periods of time in the US from the Census Bureau, and you can see this is April to June 2019, and it's the percentage of depression or depressive symptoms in the general population. This is in 18 to 25-year-olds, and what you can see here is a vast increase. So this is April to June 2019. This is April to June 2020. These are confidence intervals. So you can see that there's a big increase in depressive symptoms between 2019 and 2020. So that seems quite remarkable and doesn't bode very well. When the pandemic started, my colleagues and I thought that, okay, we will need to measure our traditional, use our traditional measures, but we will also need a special instrument for the crisis. So we called it the crisis, the Coronavirus Health Impact Survey. And it was Dr. Kathleen Merrick-Hangis, the renowned epidemiologist, Mike Millen, from the child psychiatrist at the Child Study Center in New York, and myself, who put together with our colleagues the crisis survey, which you can find online in this website. If you put in the Coronavirus Health Impact Survey, you can find it. It's available for free for all. So, and we start by asking about some background demographic characteristics. So we want to find out more about what's happening during the pandemic, what are the effects of it. So we start by asking some very simple questions like, where do you live? How old are you and all that, but how many rooms are there where you live, and how many people are currently in your home? Are you an essential worker? Then we ask questions about the physical and mental health of people before the pandemic. We do that especially for those, so that people can use this in new samples, i.e. where they don't have past information on the people they see. And we ask whether anyone has been exposed. Have you been suspected of having coronavirus? Have you had, the following symptoms that are typical of being infected and being ill with coronavirus and COVID. And then we ask about changes that are due to the pandemic. Have you lost your job? Are you attending school? How stressful have the restrictions been? So all the questions that you might ask as a sensible psychiatrist or mental health worker, but in an organized form, and things about worries that are specific to COVID, like how worried have you been about being infected, friends or family being infected, your physical health being influenced by coronavirus, and all that. And then how some basic questions about happiness and how sad you are, how anxious you are. So just giving you an overview of what is contained in this survey, in this instrument, which, as I said, is available to all. We also ask about drug use, time spent on social media, which is a particular concern, particularly amongst parents who are worried that their children may be overusing social media. So we created this new instrument, and I'm delighted to say that it has been used now, that it's being used in more than, I think it's more than 15 languages that we have translated into now, close to that. So people are using it around the world. One important thing, and we spent a lot of time, invested a lot of effort and money to do this, is to understand the psychometric properties of this instrument. So how well does this instrument do? This is the first question that you might ask. So, okay, you've created this instrument, what does it do? So my colleague, Dr. Etiology, who's working at Child Mind Institute in New York, together with Kathleen Mary-Kangas, Mike Millam, myself and others, are writing a paper which is about to be submitted to bioRxiv. And what we did was to collect pilot data in the UK and the USA using an online service, because it was very difficult to obtain, it is very difficult to obtain data otherwise from the general population, and try to collect a representative as possible through an online survey sample. And you can see that we asked adults in the US and adults in the UK, about 1,500 in each country, and parents about their children in the US and the UK. And you can see the distributions here. So all of them were adults. You have a general kind of idea. I'm going to let this stay here so you can see what we're talking about. Most of the parents were parents of children between 6 and 13. And you can see also the distribution of race here. So what are the psychometric properties of the crisis? So the first question is acceptability and feasibility. So if you were to use this measure, how acceptable and how feasible is it for people to do? So the proportion of complete service was high, it was over 90%, 95%, which is really good. We had very few missing items, so people didn't skip items. On average, it was below one item. I'm not going to answer this question sort of thing. The mean completion time is around 14 minutes for adults on themselves and parents and their children across the US and the UK. So, it would take people about a quarter of an hour to complete, which is not too long. And then the feedback we had from open-ended questions. So we had some questions where we say, okay, just write in there whatever comes to mind. It was generally very positive, with no responses indicating that people found it an undue burden or terribly annoying. At least not in these samples that I just showed you. This is kind of getting to the more technical. Basically, we were able to confirm a factor structure that we thought applied in some kind of advanced statistical modeling that we did to confirm that in test and training and test samples in this study. I can explain that more if someone would like. Doesn't matter so much for the rest of the talk though. We tested the reliability of the crisis, which is another thing. So if you ask people today and you ask them again tomorrow, how consistent are their answers? And that's very important, because you want to measure that has some consistency, because consistency is a prerequisite in order to be able to measure change. So we had a high 24-hour test-retest reliability for certain subscales of the crisis, and the reliability of the single items was generally not bad at all. So in general, we had good reliability for this instrument. So to summarize this, we created this instrument. The instrument does seem, the questionnaire, the interview, however you want to see it, it seems to be working at the basic level quite well. So the next thing we did then was to use this instrument in our in our adolescent study. So we have a study which is called Characterization of and Treatment of Depression Study. It's been going on for a few years now. We recruit adolescents, and what we do there is we recruit adolescents between 11 and 17. We do an electronic screening using the Development and Wellbeing Assessment. I don't know whether you're familiar with this structured interview, which one can use online. We do it online, so before people even come into our clinic. Then we do an in-person diagnostic interview with the Kitty SADS, which again is a well-established and validated interview. And then people are enrolled into our study. This is a longitudinal study. As I said, ongoing. The study is designed and optimized to look at mechanisms of depression, such as reward processing, reinforcement learning, and we do some very dense assessments. We see people every 4 months, some of them every 4 weeks or every week, and we have an inpatient unit as well. And people get scanned, so they get fMRI, they get magnetic encephalography on top of the clinical assessments. It's a very rich data set on which we now collected the crisis, the questionnaire I was telling you about. So I'm going to be talking today about a sample that consists of 106 depressed people and 70 healthy volunteers. This is what HV stands for. This is their age range and the mean age and the proportion females in the sample. So our first question was, okay, what happens with depression? Like we have data on these people, as I said, from when they first enrolled. And when they first enrolled, that was before the pandemic. That was the pre-pandemic era. So we know their depressive symptoms then. And then we measured again, the data I'll be showing you today is from the early stages of the pandemic. We measured again in March and in April, and twice in April, beginning and end of April. So what happened? Did the pandemic lead to a huge increase and a change in depressive symptoms? So let me walk you through this graph. This is depressive symptoms before and during the pandemic. On the y-axis, on the vertical axis, is the depression score, in particular the mood and feelings questionnaire, as reported by the child themselves, right? On the x-axis here, you have the time points. This is before COVID, some point before March. This is early March, this is early April, and this is late April. Blue is depressed, red is non-depressed, is healthy. If you just use this line here for each one of those box plots, what you see, this is the median, this depicts the median, the middle of the observations, if you like, of the data that you have. What you see is that there's not a vast increase in depressive symptoms. In fact, depressive symptoms look higher in depressed people compared to healthies, as one might expect, but it is pretty much the same at every time point. There's no big difference. Does that make sense? So let's look at it in a different way. So don't be scared by the many lines here. There's a method to the madness. This is depression score again. Now we're looking here at the months of 2020 so far until August. This includes the data we have been collecting recently. Let's look at what we get. Each line is a patient or a participant. It could be a healthy volunteer or it could be a depressed participant. And each one of those little angles here is a data point, is when we have data. What the thick blue line is the mean, is the average of people with depression, and the red line is the average of the healthy volunteer scores. What you can see is that there is a lot of fluctuation, which is understandable, but you have fluctuations, the same amount of fluctuations before the pandemic as you have them during the pandemic. Does that make sense? Both for the depressed and for the healthy volunteers. Maybe there's a smidgen more here for the healthy volunteers. Let me show it to you in a different way as well. Again, don't be put off by this. This is this is an automated system that I've created to track my participants. And what you can see here, each number here corresponds to a patient. It's a de-identified or to a participant. So you can see, for example, that there's a participant like 24123, and this person's depressive symptoms were pretty high pre-COVID, and they went down. There are others who went up, but you can see that there's a lot of fluctuation. There's a lot of people who remain stable, others who fluctuate, like people who go down, people who go up, people who go down. But overall, there is no pattern emerging to say that, oh my God, everyone has shifted quite dramatically to having more depressive symptoms at the moment. Does that make sense so far? So let's look at it in terms of how parents report. We've been seeing what children have said about themselves, or young people, you know, these are adolescents. Let's see what parents say. Well, you know, it's always important as child psychiatrists and youth mental health workers, we always try to get as much information, collateral information as possible as well. So let's look at their parents. So the parents say that, yeah, this is pre-COVID, this is early March, maybe, but again, if you apply statistics with this, or for those of you interested, if you apply a linear mixed effects model, there is no significant effect of time, and there's no time by group interaction. So in other words, there's no robust indication that there has been a big increase beyond what one would expect by chance, to occur by chance, in depressive symptoms, also as reported by the parents. So we see stable differences between the groups. So the depressed remain depressed. The healthy volunteers are, you know, far below in terms of the severity of the depression. We see a lot of inter-individual variability, as one would expect also of an episodic illness such as depression, but no overall increase in depressive symptoms. Does that make sense? Okay, now we had other questions. So we had questions, as you know, from our crisis questionnaire about COVID-related anxiety. So the question was, are you, you know, I am worried about my family getting infected. Not at all, slightly, moderately, very, or extremely. I'm sorry about the spelling error here. So what you can see is that there are a few more people with, these are percentages, by the way, and these are the response options that people had. There are a few more people who respond to the extreme ends, but they're just very few. It doesn't look like there's a dramatic difference, at least in this sample. There may be a few more people who are a bit more worried, but that doesn't come out as statistically significant. In terms of worries about one being infected oneself, again, there's not strong evidence of a difference between the two groups. You know, I think this is one person or two. Yeah, it's one person who's extremely worried, who's in the depressed group, but overall, the blue and the red bars look quite similar again. Where this changes is if you ask people about their physical health, and you can see here that people kind of say, oh, okay, people who are depressed are more likely to be worried about their own physical health. Moreover, they're more likely, understandably perhaps, to be worried about their own mental health. So people with depression are more likely to say, do you know what, I'm worried that the pandemic will have an adverse effect on my mental health. In a way, people with mental health problems make a similar prediction to what we make about the effects of the pandemic on them. So whilst we don't see that yet being expressed in their actual depression scores, the worry is there that the pandemic will make things worse. So no apparent difference in worries about infection, as I said, but worries about physical and mental health overall. Then we asked them about the quality of their relationships with their family. And you can see this is now, again, percentages on the y-axis. This is a lot worse, a little worse, about the same, a little better, and a lot better. So it's a bit flipped from what you were seeing before. So you can see that there's a lot more depressed people who say, you know, it's actually been a lot worse since the pandemic. So my relationships with my family have suffered. Does that make sense? Similarly, with the quality of the relationships with friends, you can see that a lot of people say a lot worse or a little worse. And those people happen to be in the MDD category, so have major depression. So again, the quality of the relationships is worsened somehow for them. And there are a variety of reasons. So when you speak with the patients, they quote, each one of them quotes their own story. You know, there's kind of, and I can give some of those anecdotes later on. Now, so overall relationships seem to be worse during the pandemic. This is sleep, and it's quite interesting. And this is sleep 3 months prior to the pandemic, and this is 2 weeks in the pandemic, right? Let me just draw your attention to the following. So I'm sorry, they're not scaled at exactly the same level. So mind you here, this is 20% and this is 20%. Oops, sorry. So you can see an overall shift in the whole sample. So 3 months prior to the pandemic, the majority of people say, yeah, I sleep 6 to 8 hours. Look what happens in the pandemic. This has shifted to 8 to 10 hours. And you also have more people sleeping more than 10 hours, and maybe a few more of the depressed people sleeping a bit less than 6 hours. So you have a bit more at the extremes, and this shift towards more sleeping. I don't know whether the clinicians here have a similar experience of at least some people oversleeping, sleeping in during the pandemic. Remember, schools schools were shut at that point, right? So people weren't going to school. There were also no expectations for most of them that they would wake up early in the morning, or there was a lot of struggle from their parents to get them up. This is exercise, and you can see here, just focus on the non-category. So the question is, 3 months prior to the pandemic, how many days of exercise per week did you get? And this is during the pandemic, in the last couple of weeks during the pandemic, how much exercise did you get? And you can see here that there's a great proportion of depressed people saying, okay, none, right? Can you see this here? So this is 3 months prior to the pandemic, right? Depressed, non-depressed. This is now in the pandemic, non-depressed and depressed, right? And you can see that if anything, the healthy people, were doing a little more exercise. People with depression, by contrast, doing less, it seems. Does that make sense? Time outdoors, time spent outdoors. This is another common parental thing. You know, just get out a little bit, get some sun or whatever it is. So the differences are not vast, but you can see that before the pandemic, there may have been a few. There may have been a few more people being on the 1 or 2 days. Some things may have, for some people, it may have improved. There are no vast differences in this category between the before and after the pandemic, it seems. So I'll just try to go into the discussion now. Let me just remind you what I've said so far. I've talked about the overall importance of depression and what it is and where the effects come from. I talked about the pandemic and its very special characteristics in the sense that it is really global. Maybe for the first time in recorded history, we have something like this where everyone feels that they could be affected, they could get it, with vast economic and social consequences. I talked about the measure that we have developed that anyone can use, and what its basic psychometric properties are. And I've talked about looking at depression symptoms and other symptoms in our own sample at the NIMH. And in our own sample, we don't find a vast, at least up until late April, but as you saw, even up to now, we don't find a surge of depressive symptoms in our cohort. We find stable differences. We find a lot of inter-individual variability, but no pattern that everything is going awful for any more awful than usual, at least, for any particular group. This doesn't mean that there aren't individuals, as you saw from those individual plots, who do really, really badly and had an increase in symptoms, and we had to intervene, and suicidality increased. But from our findings, it hasn't been more than the same time last year. So why, let's just go into some of the discussion. Why didn't we see an effect on depressive symptoms so far? Well, let's start with some methodological reasons. It could be that our measure, the way we measure depressive symptoms, is not sensitive enough. Well, I'm not sure about that, because this is the MFQ is a measure that is, fairly well validated. It's validated for, measuring trajectories and change. It seems a very unlikely explanation. Also, we're not just doing the MFQ, we're also seeing these people clinically. And as I said, we don't have the sense, also from all the other stuff that we're doing, all the other measures that we're collecting, that there's been a huge surge in depressive symptoms so far. The other one could be that our sampling frame is wrong. And indeed, the second study, our study, the NIMH that I presented you, is a study that is being optimized for doing in-depth studies of the brain and mechanisms and all that. So it is understandable maybe that this has certain bias. It's not a general population sample. And we have participants, some of the participants are very well off, and they haven't been hit by the pandemic as others at the moment. So this could very well be a reason, right? And it's a particular sample in a particular spot in the world, and one mustn't generalize from it about the world in general. This would be a fallacy to do. Still, though, it's quite indicative that in this sample there isn't much, which is for us was initially a bit puzzling. The other thing is, of course, some of you would say, well, the timing is wrong. Come on, Argyris, this is too early in the pandemic, right? And this seems a very plausible explanation, I think. The cumulative effects of the pandemic, social and personal, are likely to increase, and people may not have felt them, certainly may not have felt them yet. So, some of those people, people's parents were not made redundant at that point. Some of those, the fact that college would be shut and people couldn't go to college or would have to do things remotely wasn't clear back then. But as I said, even recently, we haven't seen a huge increase. But I do think that this is a very, very, very important factor, and that things will accumulate. We already see that depressed subjects may have somehow higher rates of worries about COVID and a worsening of relationships. And I think this is a very important point, that as relationships worsen, the quality of mental health in those people will decrease as well. This is a classical risk factor for depression, not having someone to confide to, being very restricted in one's ability to form relationships and all that. There are some other substantive explanations, though. One is that, as I said, this is a pandemic, i.e. it affects everyone. It's a general lockdown. And yeah, there are definitely some social groups that are suffering in particular. And it's usually the people who are worse off to start with who are suffering worse effects of the pandemic. But there is also the sense that, okay, we're all in this together. And in many of the open-ended comments that we have been getting, maybe I should have added some of those, we had many comments like, okay, I am worried about I have a grandfather who's very ill. What will happen to him because of the pandemic? I have an auntie, the classical kind of COVID worries. But there was also stuff like, oh, actually, it's been quite good for our family. We came together for the first time ever. My husband was at home in the evening and we could all have dinner together. Children said, oh, it's very nice, I can see my parents more. So kind of positive aspects of the pandemic, at least for certain types of families, during the pandemic. Imagine that this could be particularly difficult, of course, for anyone to say if their parents were essential workers or had to go and deliver food or something like that during the pandemic. But for some people, it's maybe even been better. The other thing is, school stopping has some unintended positive consequences. Anyone who works with adolescents knows that school is a big stressor for things, right? This time of the year before school starts, right, is a time when anxiety shoots up, like before exams, right? So people kind of do feel a lot worse. So all that's gone now all of a sudden. You know, okay, there's uncertainty about the school, but people don't have to go to school, they don't have to wake up early, they don't have to go in, they don't have to see people, they don't have to interact with people they don't like. So that may be another reason why the effects have been diluted so far. People may be resilient for other reasons, apart from the ones I mentioned that we can discuss later on, and may still be unclear. But let's take a step back, and before I finish, I would like to indulge me in discussing kind of a mathematical property of shifts and means. So I'll explain what I mean. So I said to you that, well, when I was showing the depressive symptoms, maybe there is a slight increase, but it's very slight, really. And in our sample, it's not statistically significant. Okay, but what would happen? So let's say we have this difference, and let's assume that this small difference does exist in the general population. Let's say that pre-COVID, the mean depression score, the average score, was 6.5. Okay, which is a realistic number in that questionnaire. And that during the pandemic, this mean score shifted to 7, just half a point. No one would quibble about half a point, right? If you said that, you know, I gave someone medication and they improved, or, you know, got worse by half a point, people would say, ah, that's nothing. I don't care about that. So it's a negligible effect for someone, you know, working clinically. Now, assume there's a common standard deviation between the two, and assume that these symptoms are distributed in a sensible way. So take my word, and I can discuss that with you about these other assumptions here. But just for the moment, think that there's only this tiny difference, a very tiny difference, even smaller than the one I talked about. I found a difference of about 1 in the mean. Let's assume that the true mean difference then is just half a point on the short MFQ. What are if that is true, what are the implications in the general population about pre and post-COVID cases? Okay, this is a histogram which counts cases here. This is the depression score. The red one is the distribution of scores, the scores that each individual would have. This is simulated. If the true mean were at 6.5, and this is the distribution of cases, sorry, at 6.5, the kind of bluish one, and this is where it's now during the pandemic, where it's just half a point higher. And you can see I have superimposed those two distributions. And what you can see is that the red one, the COVID one, the during COVID one, has some more cases here, right? They just look up above, they're taller, slightly, tiny bit taller than the others. Well, half a point can make quite a difference in the general population. 10 is a standard kind of cutoff score for the short MFQ. You know, 10 and above is, you know, a case. Well, you would have 12% more cases in the general population if that were the case. Well, you'll say, okay, I can live with 12% more cases. But let's take 20, which is quite a, you know, it would indicate quite a severe case. Then you would have a 28% increase in severe cases. Okay, now think about this. How well would your services cope with a sudden 30% increase in severe cases? How well would your mental health service cope with a sudden increase, say, of 20 to 40% in the need for beds, for example, right? Because some of those cases will need, you know, to get a psychiatric bed, for example. Now, let me just, this is for the very benign scenario that this is only half a point difference. So let's take the scenario that there's a 2-point difference, a true 2-point difference. And as you can see, this is not an unrealistic scenario. If you see some of the data from other people, in adults in particular, it's not necessarily unlikely. So you would have 44% more cases, and you would have 200% more severe cases. So you double the number of severe cases under those circumstances. This would be, for any kind of mental health care system, most mental health care systems are kind of strapped for cash and resources. This would be pretty disastrous. So we shouldn't be fooled by, you know, by standard statistical tests of significance. We should be very open-minded about the possibility that even those small differences could cause great changes in the number of cases and our capacity to deal with them. This is another way of depicting it. I don't think it's necessary now. So let me give you some conclusions. Should we worry about the mental health of young people? And I think absolutely yes. There are clear indicators that there are and will be problems. And some people are struggling in particular, even if the average, at least from what I've shown you, is not yet disastrously affected. This is the time to talk about resilience, about why some people do better than others. So it's a great opportunity to do those studies. Social determinants will be key, but this is also this time to understand how these are mediated. What is the biology of being able to cope with some of the disasters? I didn't talk much about this today, but this is obviously a preoccupation of our group. And what do we think about treatments? And I'm happy to discuss this a bit more. We have several projects going on about this and how to adjust things to the pandemic. So I'm very happy to discuss this. I would like to thank my team of people, particularly those 4 people who worked on this talk and have been collecting or analyzing data with me. And thank you all very much for your patience and attention. I'd be delighted to take questions.
Thank you very much, Professor Stringaris, for that talk. We might move to remove the slide and have everybody's name, and if they wish, they can certainly put their faces on so that if they would like to contribute to the discussion, I'll be able to see them. And I do see on our slides that we've got some of our colleagues, you know, that have engaged in research in this area as well. I think Argyris, one of the most maybe a bedbug, not to say a bedbug, but whatever that word is, it's kind of something I worry a lot about, is the distinction between symptoms and clinical conditions. And I think that working in mental health services, specialist mental health services, we have to be very careful both in conducting surveys and studies ourselves and in reporting on studies that have been found, that we clearly distinguish the two. So with that in mind and looking at what you had presented so very nicely, the household survey in the US, which is very, very large and repetitively done, like many of the other adolescent surveys as well that they've done, they really initially focus on, and please correct me if I'm wrong, on depressive symptomatology as opposed to the clinical syndrome of depression. And in that you found, as we might expect given the pandemic, that a very significant increase, 25% currently having depressive symptoms. And that's very much in keeping with our own adolescent survey that Jigsaw did. And I see Barbara is on the webinar as well and may wish to contribute. But they also found a significant increase in that youth group, you know, I think it was 12 to 25, both in anxiety and depressive symptoms as opposed to clinical syndromes. In the study, the crisis study you presented, perhaps it may be limited by the slightly smaller size, very good size for a clinical group, over 100 youth with clinical depression, but only 70 healthy volunteers. You didn't find, as you say, any particular increase in depression, which might have been initially counterintuitive. But I wondered about the fact that 2 things. One is that the kids are already in treatment. And so we're all aware of the need to make sure that there isn't a deterioration in mental state. And it might actually be a testament to the therapists that are working with the children that they've been able to, what you'd like to know is whether there was any change in either the frequency of visits or the intensity with which the therapist worked with those children in order to actually maintain their level of depressive symptoms at the rate it was rather than an increase. And the second thing then is to see why there was no difference with the healthy group. And maybe, I'm not sure how that healthy cohort was selected for that study. And if you were to look at another healthy cohort, maybe you might have found an increase in symptomatology in that group. Yeah. So maybe just to kick off with a comment on that.
Yeah, no, this is an excellent set of comments. So if you don't mind, I'd like to. There's a few kind of layers. Can you hear me?
Yes, good.
Yeah. So it's an excellent set of comments, and there's a few points that I would like to respond to. So the first one is, I think if I understand you correctly, you're saying, well, people ask about depressive symptoms, and okay, that's great, but you know, you must distinguish the symptoms, one or two symptoms you ask about, from the actual clinical condition, clinically ascertained depression, which meets criteria for caseness. I showed you here symptoms, so I agree with you completely, and this is a problem that has been plaguing depression research for a while, and clinical phenotyping is very, very important. I presented you here with the symptom levels. We could have also spoken about the interviews. But I can tell you that there would be even smaller, even less variability, because there wasn't, you know, we didn't find a change at the extremes, at the actual cases. It wasn't the case like, okay, there may not be an average shift in the symptoms, but we do find that we have, you know, a 10% increase in people who actually become depressed. So we didn't observe that with our in-depth interviews. And as you can see, we use 2 layers of clinical interviews, one with the Dorber, another one with the kiddie SADS, and we have 2 clinicians seeing the patients. So, you know, it's quite in-depth. So there is always a trade-off between how big your sample can be and how representative and how much of the clinical work you can do. Moreover, the survey that I showed you, the national survey, didn't ask the same people twice. So we must remember that, right? It is, okay, I'm going to sample back then, and I'm going to sample now. Some studies do have a panel of people whom they ask repeatedly, and be interested to see what they do. But by necessity, they can only do much less clinically than we would be able to do in this smaller study. The other thing to say is, yes, there's a good chance that our healthy volunteers are very particular. As I mentioned, the ascertainment, the sampling issue here, and that, you know, they belong to a group of super controls who are, you know, just have all sorts of ingredients to be resilient, which would be very interesting in and of itself. So I think all this applies. To be honest, I'm still very surprised that there hasn't been an increase in our depressed participants who are overall very vulnerable to environmental conditions and contingencies. So they're generally kind of quite sensitive. We haven't seen an increase in demand. Now, what is true is that starting April, we certainly offered more, but it's not like we have seen a vast surge in the demand for services either. So I must say that I am myself quite surprised about this, but I do expect this to be changing. And as I said, and as you pointed out as well, one must be very careful not to generalize this and say, oh my God, you know, clearly there are no effects of the pandemic. This is not what we're saying. In fact, you know, I'm surprised at the findings, but understanding why it is this way is very important, and thinking twice about what we expect the mental health consequences of the pandemic to be would be important.
The other thing, Argyris, you presented very nicely in your introduction was, you know, the kind of the risk factors for depression, both the family history, the psychosocial issues, and more, I suppose, a more concern now is the high rate of unemployment. And one of our participants has asked about the effect also of lockdown. And I guess within your sample, or indeed within the household survey sample, is there an opportunity to parse out some of those potential confounders and to see how they're impacting on your overall results?
Yeah, so this is something we're working on. We have another 3 waves up to now, and we're continuing to collect data. Again, you can see that this rate of data collection is possible, of course, in this sort of sample where we can follow up people. And I must say something here. One of the issues with doing this sort of research is doing it ethically. Because, you know, saying to people, okay, fill in my survey, please, and tell me whether you're suicidal, but then having no mechanism for following up is a big problem. So what we do, and what we invest an enormous amount of resources in doing, is say, okay, could you fill this in? And we follow up if there's a clinical problem. So this is kind of quite important to do from an ethical point of view. So we have the resources to do this, and we have done it repeatedly. And in answer to the question that the audience asked, we are looking into this at the moment. We do have the measures to see how people responded to the lockdown, questions about whether they thought the lockdown had affected them, and also questions about the resources they had during the lockdown. So whether they had open spaces, a nice garden to go outside, whether they had money, whether they, everything was arranged with food, whether anyone in their family had caught coronavirus. So we do have all these questions. And we do have all these questions in the large surveys of the crisis questionnaire that are being done elsewhere, except in many of those studies, there won't be data of such density or data that have been collected before the onset of the pandemic.
Just a very quick clarification question. One person was interested to know whether the young people in the treatment study, whether they were also getting medication as well as cognitive behavioral therapy, or
yeah, so about yes, the rates. So about half of the sample of the depressed sample are unmedicated at point of entry, and I maybe unusually for the US context, we are quite conservative in medicating. So, and again, we haven't seen changes in the rate at which we was required to medicate. So about half were unmedicated, and I would say that about 60% are medicated in the longer run. So we try to treat lots of these people with cognitive and behavioral therapy, which we either do ourselves or we work with other colleagues in the community to do.
Right. Another more general question, and it really goes back to the reporting of an overall rise in major depressive disorder amongst both adolescents and adults. And I guess if you could maybe clarify whether you believe in that, whether there are methodological issues that need to be considered to state that yes, as the decades go by, that there is a real increase in depression in both young adolescents and in the adult. What sort of factors might be contributing to that? Yeah, well,
two things to say about this. I'm not doing that much epidemiology anymore these days. So there are other people who will have a much more informed opinion. But from what I've done myself and from the literature, what I can say is that those so-called secular trends are quite tough to investigate because there are things that change. For example, instruments change. The way you measure depression changes. There are issues about the meaning of reporting in your depression that changes. So people are much more likely to say now, oh gosh, I feel depressed, rather than adopt a, chin up mentality, which was, which was what people required more in the past, to just go through it. So now it's much more encouraged perhaps to talk about these things. So it's not, there are factors that are not easy to disentangle when one is asking those sorts of questions. And we must always bear that in mind. Having said all this, well-conducted studies, or studies that are as well conducted as they possibly could, suggest that there is an increase in emotional disorders and depressive symptoms. So maybe this is the case, and maybe there are societal factors that contribute to it. Rising inequality is something that people cite. There's all sorts of plausible explanations that one can look at. But I just want to add again, it is a difficult sort of research to do. I am concerned about depression phenotyping in general, what you said before, both in epidemiological studies, but also in studies in medication studies. And as you know, one of the things about depression is that we have very high placebo rates. Why do we have those high placebo rates in the medication trials? Well, that tells you something about spontaneous remission, tells you something about phenotyping, about false positives, how depressed someone is when we call them depressed. So there are all sorts of complications in this. So I'm sorry I can't give you a definitive answer about whether I believe in this or not. I'm open to the possibility for sure, but I'm going to be mindful about the methodological pitfalls with this.
And as a take-home reminder for our audience, what would you say the rate of depression, major depressive disorder, clinical syndrome in prepubertal kids, in young adolescents, and then in adults are? You see such variations written in very well conducted and by very excellent clinicians. At times, you sometimes think, did I get that wrong, or have I been quoting the wrong percentage?
Yeah, so let me just, again, I would like to take a step back with this. So we talk about depression as if it were one kind of, one real natural kind that is invariant out there. And I think that view can be challenged. So is prepubertal depression the same thing as the depression of an 80-year-old, for example, right? Is adolescent depression the same thing as a depression in a, is the depression that a 14-year-old girl has the same as that of a middle-aged man? It is, this is not entirely clear, and the continuities are, if anything, partly established. So there are studies that say that any depression pre-puberty doesn't necessarily continue as depression later on, whereas adolescent depression is a bit more likely to continue as adult depression. But there's a lot about possible differences in the etiology of each one of those phenotypic manifestations. There are some people who find more continuity, like the work by Professor John Luby from Washington University. There are others, like the previous research by Dick Harrington and Mike Russell, that find that there is not so much continuity. So we must be careful when we talk about depression as if it were one kind of real and the same entity. Then there's another confusion about lifetime prevalence, point prevalence, 6-month prevalence, and that can get, people can get confused about that as well. There are people who say, oh my God, in terms of lifetime prevalence, everyone has a mental health disorder, and depression and anxiety are the most common ones. So, 80% or something, literally, about lifetime prevalence by the age of 50 or something like that. So one needs to be careful about what exactly we're talking about. One well-conducted study by Jane Costello and Adrian Angold, I think, found that by the age of 16 there's a 10% probability of a cumulative probability of having had depressive episodes in the past. So one needs to be careful about what exactly we're asking about. And as we said before, where do we put the threshold? How impairing does the symptom have to be? So these are difficult things to ponder, because there's also kind of this, there are some sociological and other issues that come into play here that this is not my area of expertise, but clearly people who have depressive symptoms suffer. So no one wants to deny the suffering. But on the other hand, whether these people do need to be seen by a psychiatrist and be given medication, for example, is a different question. So what often happens, therefore, and there's a perversion of healthcare systems, is that very unwell people don't get seen, and people with some levels of symptoms do get seen because they're labeled as being depressed. So there are kind of those paradoxes of practice as a result, because both are labeled as having depression, and one may have more resources to access services than others. I don't know whether that helps as an answer. Just I want to be very.
It's a great help, but I have to say that you still haven't given the audience a takeaway number. Now, you might find that hard.
Yeah.
I myself kind of certainly have read that maybe depression pre-pubertally would be about 1%, maybe about 5% in adolescents. Obviously, girls, with puberty and even the staging of puberty, it increases hugely. But I've also read by the time they reach 18 that they share the same prevalence, the 1-year prevalence of depression as adults, which has been quoted as about 20%. So that seems a lot when you think about it. And I worry that there's a real risk of, if we, first of all, if we're not careful in our reporting of the difference between depressive symptomatology, i.e., feeling sad and individual symptoms, as opposed to meeting full criteria, there's a risk that far too many people are given a diagnosis, and therefore it dilutes the real pathology in those children that have, and it's not even that it's the more biologically typical depression, but those that are really impaired by their cluster of symptoms over a period of time.
So let me say that I share your concern. The complication there is, I think that again, many of the big studies that are being done, the interviews are not conducted necessarily by clinicians. I'm not saying that this is necessarily therefore inferior, but there may be a slightly different practice. You know, people may do this differently to how you might do it in your clinic and how you might decide. So the threshold for caseness will be different. The other thing is that we know from the field studies that have been done by the DSM that that the reliability of the assessment of psychiatric disorders, including depression, can vary quite a lot, and the consistency is not as high as we would like it to be between clinicians. So that all can contribute to those fluctuations. But I do want to say that even if depression hasn't reached caseness, the people who have high rates of depressive symptoms are at increased risk, and the fact that they don't reach threshold doesn't mean that they're not impaired, or that they're not at high risk of getting this. Now, whether these people should be medicated or not, this is a different set of questions. But depression does seem, from what we know so far, to be a continuum of symptoms rather than, you know, having some sort of being a separate category from depressive symptoms. And that's one of the challenges, both in depression but also in anxiety, another psychiatric disorders. Yeah.
So just, we would love to chat with you longer. I'm very aware I've taken the liberty of indulging myself in chatting with you and asking a couple of questions that were posed. So apologies to the audience, it's nearly 1:45, which is our latest. It's probably a testament, Argyris, to how people enjoyed your presentation. I might end the session for today by thanking again all of you who have attended, thanking most sincerely Argyris for presenting to us, reminding our audience that the next presentation that we're having next Friday is by Professor Robert Maunder, and really we're looking at reducing what Argyris has spoken about. Is we expect there to be significant consequences of COVID. So it's how do we reduce the harmful impact of COVID, again, on ourselves as healthcare professionals. And he's got one particular area that he'd like to introduce to us as a possibility. Could I remind the audience as well that we're having our own UCD conference on the 16th of October. And we would be delighted if you would all consider joining that conference. It's from about 9:30 to 1:30, and CPD points will be available. And we hope that there will be a combination of breakout rooms, so it'll be more interactive. So once again, thank you all for joining. It looks like a better weekend, although the forecast is bad. So stay safe and see you next week. Thank you, everybody.